Hello, all. I see folks filtering in. Welcome. We're looking forward to getting the webinar started today. I'm going to hold off just as people are coming in. Give it another second. And we'll go ahead and get started. All right. Hello, everybody, and welcome to today's webinar, Pathways to Scaling Playful Parenting Programs, where we'll be talking about enablers and barriers to scale up. My name is Tanya Smith-Sreen, and I'm a Knowledge Management Officer at FHI 360. And so before we jump into the webinar today, we have some really exciting content lined up, a very rich discussion with our panelists on the line, who I will invite to keep their videos on for now. But I did just want to cover some housekeeping before we jump in. So we will be recording today's webinar. The link will be sent out via email to you all and posted on FDAN's website. We really encourage you to use the chat to introduce yourself, get to know one another within this space, make some connections. So let us know your name, your organization, and where you're calling in from. And finally, we'll have some Q&A time towards the end of the webinar following the presentations from our 5 different panelists, or 5 different Playful Parenting programs and the implementation research. So please use the Q&A box, which is right next to the chat box, to submit any questions that come up during the webinar. And we will get to as many as possible by typing our answers during the presentations. And then during the Q&A section, we'll have some live responses. And with that, I'll just cover our agenda before passing it over to Jill from the LEGO Foundation for our opening remarks. So we'll start off with these opening remarks. We'll get into a presentation on the implementation research being conducted on the Playful Parenting programs. And then we'll have some presentations from each of the Playful Parenting program partners, who will get into introductions for once they start presenting. As mentioned, we'll have some time for both Q&A and some pre-prepared discussion questions, though we'll try to prioritize any questions that come in from our participants today or our attendees today. And then we'll close it out with some closing remarks. So with that, I'm gonna stop sharing my screen and pass it over to Jill Pop from the LEGO Foundation to share some opening remarks.
Great, thank you, Tanya. Welcome and thank you for joining this webinar today. I'm Jill Pop from the LEGO Foundation, and I'm really excited that our implementing partners have agreed to share the great work that they're doing on behalf of children and families. Sometimes families can benefit from extra support during their child's early years, and we have good evidence that this type of support can benefit caregivers and children. But I'm sure, as a lot of us know, that expanding this work to more families and geographies while maintaining quality can be difficult. At the LEGO Foundation, we wanted to know more about the key aspects of taking a program to scale with quality. You'll get a sense of what this looks like throughout the webinar today. But at the Foundation, we have been particularly inspired by how our partners have incorporated the evidence they've learned from this project into implementation changes that have hopefully led to stronger programmatic outcomes. We all know that in the beginning of a project, we have an implementation plan, but then reality happens. There are government changes, environmental disasters, global pandemics, I could go on. But being open to iteration and adaptation along the way is obvious and necessary, and oftentimes this leads to new learnings. This idea is a theme that will come up in the various presentations we have today and in the discussion that will follow. I want to close by thanking our implementing partners for the work that they are doing, and for our learning partners, FHI 360 and ECDAN, for helping us to share these important findings. Over to Karina.
Thanks, Jill. I'll go ahead and share my screen and pass it to Karina Omueva from FHI 360.
Thank you so much. Thanks, everyone. It's so nice to be here with you. My name is Karina Omueva. I am the Research Director for the Research and Evaluation Department at FHI 360, and I am the Project Director for the Implementation Research for a Playful Parenting Initiative. I will talk a little bit about the role that FHI 360 plays for the Playful Parenting Initiative, and this is the first time that we're introducing ourselves as a community of practice with our Playful Parenting partners. So we are, FHI 360 is an implementation research partner and a learning partner to the Playful Parenting Initiative. We have started in 2020, just as the pandemic was starting up. And we are working in parallel with the programs that you will be seeing, we will hear from and see featured today, and working kind of side by side, developing a research framework and posing questions to learn about how these programs can be effectively scaled and sustained. Evidence from this study, as Jill mentioned, will really help the entire community, but and particularly these partners as they go to learn to learn how these programs can be effectively scaled and sustained. We are hoping that this is going to be an opportunity for everyone to learn how parenting programs can be implemented in changing contexts in different parts of the world, and then make it easier for everyone to draw lessons about how to implement and bring to scale their programs, early childhood development and parenting programs around the world. So we can go to the next slide. This is just to give you a sense of the geography of the partners that you will hear from today. FHI 360, we're based in Washington, DC, but we have our research activities across all of these countries. We work with partners really closely in Bhutan, in Serbia, in Rwanda, and Zambia. We are also working with learn from the Guatemala team about their work on Juega Conmigo. So let's go to the next slide. Just really quickly, we are not just a research partner, but we're also a learning partner to the LEGO Foundation. And we work with the partners as part of the community of practice. This schematic here shows you the process of developing, really generating evidence, getting data, creating these feedback loops with partners and with the LEGO Foundation consistently. Now we've been doing this for 3 years. We have 2 more years to go. And as we go throughout this process, it's a continuous dialogue. So we're not evaluating, but we are generating knowledge and learning as we go. So we're hoping that through this process, this entire community can benefit from this experience and from learning from each other. Next slide. Just quickly to share with you the framework that we're using. We're drawing on the ExpandNet framework, or WHO framework for scale up. This framework here just graphically shows you the elements that we're looking at. So let's go through them really quickly. First one is the innovation. And we're looking at how these programs that have already developed innovative approaches to reaching families, to reaching caregivers and providing them support. How are these programs and program teams making them scalable? That is possible for the host organizations or the user organizations to really adapt and to integrate and implement at scale. What changes and adaptations are they making? We're looking at the composition of the resource teams. That is the organizations that are seeking to promote the innovations, our implementing partners that you will hear from today. What kind of skill set, what capabilities they're bringing to the table, how they're working with the operating environment, how they're thinking, what changes they're making in their decision-making process. Next one. We look at the resources and capacity with a system. So that is the user organization in this framework. We are looking really closely at these relationships and advocacy processes with the ministries of health, ministries of education, other government agencies that are involved at both at the national and local level, how they are accepting the program, what are the changes that they're making in response to seeing the innovation and seeing the process of scale up, are we able to see that there is a pathway to scale and sustainability based on the capacity and the resources that the user organization has mobilized in response to this opportunity. And next one. And then, of course, the enabling policy and institutional environment around the program is important. We're looking not, as I mentioned, at government partners, but also at the policy framework, at the community norms, both at the local level, the national level. And then we're also looking at to see whether there's broad buy-in for the program, both at the community level as well as with policymakers. So it's a broad-based, comprehensive research that we're hoping that in 2 years' time we will be able to share a lot of evidence from. Again, just to show you the framework that we have developed and the research questions that we're looking for. This is research constructs, rather, that we're using for the implementation research. For each of these programs, we're looking at child and caregiver outcomes, with the question being is, as these programs go to scale, how do they affect child and caregiver outcomes at larger scale as they expand geographically and vertically, horizontally and vertically? How they change community norms around parenting, especially around father engagement. A lot of them are focusing on father engagements, as you will hear. A big portion of this is the workforce, how programs train greater and greater number of frontline providers, how they support them, how they provide supervision and quality assurance as providers engage with caregivers. Programmatic factors include, as I mentioned, decision-making, adaptability, iteration, as well as cost structures that partners and resources that partners bring to the table. And then enabling environment is everything around the policies and government receptivity and government preparedness for integrating this innovation into the system at scale. Next slide. I will not go through this in detail. This is just to show you that these programs are diverse and you will hear from them directly. But the way that we're thinking about this is generating evidence around all of these programs, understanding the diversity and the differences between them, differences in provider status. Some programs are working with health assistants or health professionals, paraprofessionals. Other programs are working with volunteers. And I'm sure a lot of people in the room here are also working with different types of providers in different contexts. So how does that affect provider quality, the quality of services that they engage with caregivers? And then what are the modalities? Are they group sessions? Are they home visits? How frequent are these? What is the intensity? What is the dosage of that engagement? How do we learn from that differentiation in different contexts about the impact that can have on the caregiver and child outcomes, and how sustainable that is? What is the level of intensity that can be sustained and scaled? And so, of course, this is a really massive opportunity for us to generate so much learning for the early childhood development community as a whole, but also provide a lot of learning as we go for this community of partners and for our funder, the LEGO Foundation. So with that, I think that I will, without further ado, pass it back to Tanya and to introduce our panelists. We're not sharing a lot of our research today, but I'm hoping that this gives you a sense that from these programs, there will be a lot of evidence, and that you kind of put that on your radar, and you will be hearing from us in the future. Thank you so much.
Thank you so much, Karina. So with that, we are starting out with the Bhutan presentation. So I know one of our panelists, Karma Dienka, is having a little bit of trouble getting on the line. So Emily, I'm not sure if you'd like to step in, or we can jump to the next presentation while she jumps on.
No, it's fine. I'll start off for Karma, and hopefully she'll be able to join in the meantime.
All right, take it away then.
Okay, sorry, Tanya, could you help me to turn on my video? It won't let me.
Yeah, sure.
Great. So today I'll be presenting on the Prescription to Play program in Bhutan, which is delivered through the health sector and is offered at national level scale. As Tanya mentioned, I'll be representing my colleague Karma, and you have to have some patience with me for this kind of last minute change here. So in the next slide, I'll talk a little bit about the kind of core programmatic activities that are happening in the Prescription to Play project. We call it P2P. So there's three main activities that make up the core project, which is the training to in-service health assistants. These health assistants work at clinics and outreach centers all over the country. And the first level is that the master trainers, who are often coming from the health assistants, they're called core trainers. They train health assistants at the district level. And after the training, then the health assistants deliver group and individual sessions to caregivers of children aged 0 to 3. The group sessions, as you can see in the photo, they happen at the health center, usually outside or in the clinic. For caregivers of children aged 0 to 3, there are 12 sessions which cover topics including early stimulation, responsive care, health and nutrition, such as breastfeeding and complementary feeding, as well as caregiver well-being and men's engagement. And then we also couple that with individual sessions, which are which in the individual session, it's a one-on-one session between the caregiver and the health assistant, as well as the child, as you can see in the photo. And in that session, the HA has some time to do one-on-one counseling with the caregiver, to conduct a child development screening with the child, to conduct an individualized play plan based on the child's age and development, and also provide any referral for specialized services if required during the screening. So the P2P project has been through many phases and iterations over the years, and many different projects which have informed the kind of current design that we have now. And I think it's really important to emphasize on this phased approach, since it's been really critical to finding that right mix of what works at scale. So we can start all the way back in 2016. There was a early literacy and maths program that was more targeting the 3 to 6 age range. But that learning from that project helped this project to determine which service provider would be really the right choice to move forward. So they were looking at a couple different service providers, health assistants or community health volunteers. They have slightly different roles, slightly different networks. And from that pilot, from that experience, they were able to determine that the kind of right service provider to go with through the health sector would be the health assistant. Then in 2017 and 2018, they piloted the first version of Prescription to Play. This is before the Playful Parenting project that's in place now. And this was done in 2 districts, so it was much smaller scale. And the overall aim of this pilot was to test the overall effectiveness of the intervention. So does this core model that I've just explained, does this really work? Are we going to see a change in outcomes for children? And we did indeed see a change in development outcomes for children and caregiver practices as well. And so decided to bring this together with the government up to a further scale. And that's where the P2P project started. P2P, we divide into 2 phases from 2019 to 2021-22. First, we went to 5 districts, and it was really testing a scalable model. So the pilot, we knew it was small scale, but then in phase 1, we knew we wanted to change our model a little bit so that it could be done at scale. The way that our training was done, the cascade model for training, the way to do supervision at scale, all of this was kind of rethought and reconfigured for phase 1. And also the evaluation was more focused on a continued effectiveness with a scalable model. And now we're in phase 2, 2022 to 2023, and we're now reaching 15 new districts plus the previous 5 to reach all 20 districts in Bhutan. And our main focus now is on maintaining quality at scale. So in this slide, I'm going to talk about how things kind of have changed from phase to phase and how we've added to these core components that I introduced earlier with the learnings from each phase and adding in new components to really strengthen the quality in the program. So in the pilot, as I mentioned, if you click, some orange should show up. Yes, there we go. So the pilot was really about getting this kind of core program, this core Building Brains program, right. So making sure that it's that the group sessions are appropriate, contextualized, that we're covering the content that was required, and that the individual sessions include that right balance as well. So that was the kind of the main focus of the pilot. Then if we look at the training over the phases, we've had lots of different iterations on the training to strengthen training. In phase 1, we, in addition to the in-service training of health assistants, we added in a training on quality improvement, also in service, and this was done virtually in phase 1. And then another learning from that is that we redid this again in phase 2, but added in an in-person component with virtual follow-up, and also added in a refresher training. So it's both a quality improvement and a refresher training that we learned over the years, that we needed this kind of extra emphasis on quality improvement. Another very exciting part of the training that we've added in now in phase 2 is a pre-service component to complement the in-service training. So now in Bhutan, every health assistant, when they go through their training to become a health assistant, they receive university courses on early childhood development and on how to deliver the group and individual sessions, as well as the child development screening. On the group session side and individual session side, we've also made some adjustments and additions to the core program. In phase 1, we added in, thank you. We added in 2 apps. So we know that going to scale, there's a bit less of that one-on-one interaction and a bit less of that a high level of support that you can have in a pilot project, for example. So we wanted to make sure that we could still, that both for HAs and for caregivers, they would have a resource where they could go and get all of the information that they would need it. And so the app was that for us, a scalable model. In phase 1, we also tested and developed a mass media campaign, which was then rolled out in phase 2. So we really took time in phase 1 to learn about the types of messages that work well and what kind of messages we needed to focus on when going to national level scale. And we're able to launch a radio and television campaign to complement the core program in phase 2. We also, in phase 1, had a formative evaluation. We also had, we were very lucky to have this partnership with FHI and have so much information coming out from the data that they were collecting. And we really took a lot of time to use and understand this information and made some changes in phase 2. In phase 2, we spent a lot of time working on a quality framework and a quality observation tool, which could be used at different levels. And then we also added in play cards to strengthen the individual sessions. Great. So I'm actually just going to go through the individual session strengthening in a little bit more detail, and I'll skip the rest for now. But so we knew kind of one thing that we found from phase 1 was that we needed to strengthen the individual session component. We knew that from the data that we were receiving that sometimes the child development screening was taking a little bit too much time. But also we knew that this was a really key area for sustainability for us, since the MOH had a very strong commitment to continuing the child development screening in particular. So over time, we were able to, if you click through, add in some strengthen the training on child development screening to make it much simpler, so that the HAs were able to deliver the child development screening in a short amount of time. We added in play plans and made that part of all health services. So even if they are not receiving a screening, they're not at the right age to receive a screening, HAs can use any one-on-one interaction to include a little bit of play and a little bit of discussion around play with caregivers when their children come to receive vaccinations and things like that. And we also introduced play cards, which are a job aid. They come from the USAID Advancing Nutrition and have kind of been adapted over the years. But these are a great aid that the HAs can use to answer common questions from caregivers. So I think I'm at my 8 minutes. I'm gonna pause there and hand it back over to Tanya.
Great, thank you so much, Emily. Thank you for jumping in. We're excited to have some more questions and discussion on the program, and we will share these slides out afterwards so people can kind of review the content there. And we encourage you to submit your questions into the Q&A box as well, so we can keep track of them. And with that, I will pass it over to Mila from UNICEF Serbia, who present on the Playful Parenting Program in Serbia.
Thank you so much, Tanya, and greetings from UNICEF team from Serbia to whole Playful Parenting community. I will jump immediately on the sustainability and scalability as our main topics for today. So in order to achieve sustainability and scalability of Playful program intervention, UNICEF made a strategic decision from the beginning of the program implementation to strengthen the already existing public platforms for service delivery by adding in a quality component, and not only limited to the content and actually to what service providers do with the parents, but particularly focusing on those changes related to the way of how they deliver service to parents and caregivers. The key innovation was to integrate playful parenting interventions in a regular and routine work and visits of medical practitioners, home visiting nurses, which has universal coverage in the country and up to 10 visits in the first 1,000 days of a child. And in addition, program actually brings in a spotlight cooperation with the preschool and community services, so to prevent already observed risk of understaffing of health services. So just to dig a little bit deeper in the thinking behind, I want to draw your attention on the next slide. So you can go to the next slide. So if you take a look at it, you will see that we try to draw the roadmap from the perspective of parent in the one community, and to see, for example, if I become a parent in any place or someplace in Serbia, what will happen to me and who are the new people and the new institution that will become a part of my life, or how many doors actually I would need to open for the benefit of my child. So we envisaged and imagined with our Playful Parenting program one particular goal for the parents in Serbia, that all of these doors should be open when parents knock. Meaning in a more technical and programmatic language that we are used to it, that we should have in place a clear set of quality standards of service across different sectors, so that should be delivered to parents. But even more, not just to have a clear set of the rules and set of the quality standards in each sectors as a silos, but even more beyond this, it is imagined that people behind these doors in a different sectors also actually know each other, collaborate with each other, so that the old doors are the right door for parents when the parents knock, which is particularly important for those parents who will need support from different practitioners and sectors because of multiple risks to which they are exposed, such as poverty, disability, and discrimination. So as this requires a range of multi-sectoral change strategies and strategic pathways to scale to be in place at the different levels of policy formulation, advocacy, management, governance, and quality of service delivery, we have combined in our program horizontal approach. So we started with the building capacity in 6 pilots and transferring knowledge in 29 learning municipalities, and also vertical scaling up approach working at the national level. So to track the progress and to stay relevant and evidence-based, we have relied heavily on the evidence that fed us from the implementation research, and thank you for that. And at very early stage, we have become aware, and you can see that in the next slide, that if everything seems to be going well, we obviously don't know what's actually going on. So I just want to briefly highlight the key learnings that informed and shaped our iteration throughout the program implementation, which we can see on the next slide. So we have learned that additional efforts were needed to translate innovations into the standardized practice, that invests should be put in the building strong monitoring and supervision, especially supportive supervisions of professional work, and that there is a really room for improvement in the bringing the quality in the session itself with the parents by strengthening behavior modeling skills of frontline workers, enhancing responsiveness to the families, having more greater focus on social emotional support, and also plus the more adapted legal framework, so for the purpose of the reduction of the burden of frontline workers. So some of the key actions that you can see in the next slide were taken within each of new iteration. We really deep dive into building practical skills of frontline workers for responsive modeling child-parent interaction play, followed by developing specific skills to provide constructive feedback to caregivers. And this was delivered through tailor-made mentoring for the frontline workers, which also is followed with development of the supportive supervision module. And we are proud that the training for the supervisor was already implemented by the Institute of the Public Health. We are also partnering with the National Public Institute for Health to strengthen M&E system. And with this, actually, digital module for home visiting is to be integrated in the broader health sector digitalization process, which is currently happening in the country, and it is led by the Ministry of Health. In addition, at the national level, we have in place now professional methodological guidance for home visiting nurses, which fully integrate the nurturing care framework, and it is adopted by the Ministry of Health. Also with the training, Playful Parenting training package, which are accredited by the Chamber of the Health Nurses, providing ongoing learning opportunities for the nurses, also being integrated in the pre-service curricula. So just to have a look in the future, in the last slide, next and the last, that actually when we look forward and in the future, the good thing is that at the beginning of this year, 2-year work plan is signed by the Ministry of Health and other line ministries between the UNICEF and the Ministry of Health and other line ministries, and that the Playful Parenting is one of the key outputs within this plan. The plan is signed within the 5 years of the country program cooperation framework. However, although this lays the foundation for scaling, what we are aiming for is joint developing of scale plan with the clear pathways to scale agreed with the government, with the timelines and budget requirements. For this, we should be wise, and we already envisage that it is necessary to connect our program with the government priorities as well, which are listed as the first priority related to pronatalist policies, and then ending violence against children and supporting mental health of young children and youth as well. I will stop here and looking forward to questions.
Wonderful. Thank you so much, Mila. And with that, I'll hand it over to Grace Umulisa from Rwanda, the Rwanda team.
Hello, everyone. I'm Grace Umulisa. I work for Sugira Muryango program, and I'm happy to be presenting on behalf of Sugira Muryango team today. So we are going to present about the pathway to scaling Playful Parenting support, enablers and barriers to scale up, as our fellow colleague who already presented. So the Sugira Muryango program is a family strengthening initiative which develop parents' capacity, and we work with the vulnerable families. And each family receives an individualized home visit using active coaching. This active coaching and this home visit allows the customization of the materials to the family uniqueness and to the family's strength as well as the family's needs. So they receive 12 modules and 2 group sessions, the welcome and the closing sessions. And this 12 modules covers both standard content on early stimulation, and including nutrition, hygiene, as well as family functioning topics, including problem solving, conflict resolution, or stress management, to address the risk of family violence. So there are 12 modules, but they are all in this two kinds of content. So the program is designed to be flexible to all family structures, including the dual-headed household, the single-headed household, as well as the multi-generational household. And we have also a large focus on male caregivers engagement with the families with male caregivers. So there is an emphasis on both visuals, messaging, and flexible scheduling to be able to engage male caregivers. We in the expanded version, we have seen that 75% of enrolled male caregivers have attended all the 12 modules, which is a huge result. We have another major focus of the program, which is the Playful parenting. All the sessions are followed by a 15-minute play session between the parents and the children, and they use homemade toys. Our intervention is to encourage the parents to make their own toys, and they coach them on how to play with their children using age-appropriate play activities and engagement of techniques such as serves and return. So lastly, we are a strengths-focused program, meaning we focus on reinforcing the strengths and exist within families and communities instead of focusing on existing deficits. So this is encouraging our families to have confidence in their own ability and to take actions for the development of their families and their children. Next, please. So the program has gone through several iterations, including the initial start for families affected by HIV, an important component happened between 2007 and 2009, when qualitative research was conducted. This research was conducted on mental health problems among children and adolescents affected by HIV and AIDS, and also on resilience in the Rwandan families affected by HIV/AIDS, including parenting practices, relevant contracts were identified and efforts were made to understand the local context and the cultural dynamics. Now we are conducting the expansion program, which is aims to reach approximately 10,000 families in Ubudehe 1. Ubudehe are categorization we use in Rwanda to categorize the families' capacities. So we work with the most vulnerable categories, and with this expansion, we work with more than 10,000 families in 3 districts, and we have also worked with engage the government in the implementation of this expansion, including RODA, Migeprof, Minaloc, and NCDA. So these bodies have helped us to meet the needs of the families and larger government priorities. So next, please. So for the Sugira-Muryango Christ randomized trial, we have very good results. We have the pre to post intervention study outcomes, and we have also the 12-month follow-up study. So for the pre to post intervention, we have tried the outcomes, including access to more stimulation materials for children in the home. We have also the increase in caregiving engagement and Playful parenting. There is publications around this result. I will not take much time on this. I can jump to the next slides. Everyone who wants to use this, to read this publication can access them. So due to the positive result from the CRT, we have prepared this expansion we are implementing. I will not take so much time on the explanation around the expansion, but I can say the changes we have made. So the current expansion program works with children from 0 to 36 months in the categories I mentioned. And the program is not only expanding its reach, we are also scaling the strategy called the Play Collaborative. And this Play Collaborative is a system of stakeholders engagement, which aims to promote local ownership and the increased program oversight. There is also a smaller embedded study, which not only collect information on effectiveness, but also on implementation of the program and the impact of COVID. We have also very good results of this study. You can access this also. And we also tested our strategy for scale and the measuring intervention effects when Sugira-Muryango is implemented using the child protection government workforce, the ISO I mentioned. So a new evidence-based implementation strategy that allows for scalable and sustainable delivery. So next, please.
Thanks, Grace. I'm going to have to jump in so that we have time for discussion, but we will share these slides out afterwards.
Okay, thank you so much. And yeah, the next slide we are about the results of the expansion, and we have the report you can access also. Thank you so much.
Great, thank you, Grace. All right, so with that, I will pass it over to Gibson Jimunya from UNICEF Zambia.
Thank you very much. I always have a problem with my video. I don't know that it can help me. It doesn't always sometimes work. But I'm making this presentation on behalf of Zambia. Unfortunately, my colleagues are not around Zewe and Cecilia. We can go to the next. We can go to the next. This is just a cover. I will not take much time on the Lego. Those are just the results that we planned. We can go to the next. Basically, it was just to improve playful interactions. And this is just a geographical coverage and also the program scope. Basically, we planned to do interventions, service delivery in Katete and Petauke districts. And also at national level, we are doing some programs on policy and systems strengthening existing services and multi-sectoral coordination, which goes down also to the lower level. We can move to the next. So anyway, those are just the components that we are dealing with, basically, which is the enabling environment systems, strengthen capacity building, and also strengthen service delivery. Then we also have a component of communication and visibility, basically to just promote playful parenting. And basically that's where we have usually the parenting parenting month program. We can go to the next slide. I think these are the major components that in terms of the strength and service delivery that we are implementing. Basically, in order for us to scale up, we had to come up with some interventions that are going to reach the families, the communities. So basically, one of the key issues that we are doing is it involves establishment of community managed parenting hubs, which we call INSACAs, basically, which involve the whole community, and they become a hub for delivery of integrated services by government sectors. So basically, when we talk about health, under 5, all these are provided by Ministry of Health, early learning by Ministry of Education, nutrition by the nutrition component. So basically, that is then when we come to the early stimulation and parenting, we have the Ministry of Health leading on that. And one of the key issues that are there in this integrated hub or center is the early stimulation component, basically, which becomes a platform for demonstrating how playful parenting should be or can be done in a home state, so that the parents can go back in their homes and be able to replicate the skills that they are getting. So basically, this becomes one of the key sustainability issues, because we are talking about the service delivery is done by government sectors. So it's not something new that we are only creating a platform where all these services can be delivered. Then the other component that we are doing is the home visitations, basically by trained community-based volunteers. So these are already existing community-based volunteers under the Ministry of Health that have different roles, but we've incorporated playful parenting so that they are able to incorporate that as they interact with the parents, and they're able to help them improve their skills in terms of playful parenting. The other issue is the capacity building. In order for them, for the community-based volunteers to be able to do this mentorship, this supervision, we are training them, continuously training them through a package that we have using the CCD and also some of the adapted materials that we have developed. So I think one of the key issues that we've done is using the network of already existing community-based volunteers, so that we are not recreating a system that is not going to be sustainable. So we are trying to look at sustainability using that mode, incorporating playful parenting in what already exists, and also the ongoing parenting counseling within homes, so that we are able to interact with the parents and ensure that they've got relevant play items, play materials, play skills. I think one of the key issues that we've also done is to integrate this playful parenting in the health services. When they go for under 5, we have components of playful parenting. And also, we have also developed a module on group counseling, because when they go for health services, it may not be possible to do individualized counseling for all the parents. So we've developed a module for group counseling, where we are training all the health workers in the target health facilities. We can go to the next. The next slide is basically just looking at the neighboring environment. I think one of the key issues that we are trying to do is to embed this into the strengthening the ECD policy framework, so that playful parenting is really strong in those policies, in the policy environment, and also improving the M&E system. How do we get information to see that we are getting the results that we want? But it's also looking at issues of standard setting, guidelines for delivery. If we are incorporating playful parenting in the existing services like the antenatal, the nutrition, the education, we need to provide guidance and also the tools to use. So that is one of the items that we've been working on to ensure that we strengthen that. And I've already talked about the capacity building. We are doing the capacity building to ensure that the different actors at different levels are able to have the capacity, have the skills to be able to help the parent improve the parenting the playful parenting skills. Then one of the activities that we've been nationally doing is a national, which is a public campaign, the playful parenting promotion. So basically using social behavior change methodologies, public campaigns to be able to raise the issue of playful parenting at national level. You can go to the next. Yeah, so I've talked about the multi-sector policy strategic framework. And all these we are looking at, when you look at sustainability, we are looking at integrating all these in the national systems that are already functioning and see how we can strengthen that. And in order for us to deliver playful parenting, there are different actors. That's why we are looking at this multi-sectoral coordination. We are looking at including the indicators in the health management system, community health management information system, to ensure that playful parenting is incorporated, and this is support we are supporting the rollout of this. One of the key issues that we are also doing to scale up and also to improve sustainability is to incorporate most of these playful parenting courses, knowledge, methodology in the training of, for example, nurses curriculum. And we've trained nurses to ensure that when nurses are trained and different health workers, they have got a component of playful parenting, which they should be able to disseminate at the ground level. Then there's the integration of playful parenting in under 5 activities. I've already talked about this. And also ensuring that one of the issues that we are doing is the development of ECDSAFE's quality assessment tools to ensure that how do we measure quality? What does quality look like when we are doing all these activities? Then we are also integrating playful parenting in the ECE teachers curriculum. So basically we are looking at integrating playful parenting in most of the training programs so that the people who come from those training programs are trained at INSAFE's level in terms of playful parenting. We can go to the next.
Okay, Gibson, I might have to ask you to just wrap up quickly.
Yeah. So here, basically, we're just looking about the 8th National Development Planning, which basically is pro-ECD, the multi-sector, the supporting of the incorporating curriculum, and also the continuous engagement with parliamentarians, which we are doing to ensure that playful parenting happens in the communities. I think this is my last slide. Thank you very much.
Great. Thank you so much, Gibson, for that great presentation. All right. And so with that, we move to our final presentation. So I'll ask Linda Garcia Arenas from Child Fund Guatemala to turn on her video and walk us through the last slides.
I cannot open my video.
I'm turning it on for you.
Okay.
Let me know if that works.
Thank you. Okay, so hello everybody, my name is Linda Garcia Arenas. I am the project manager of Come Play With Me in Guatemala. I'm going to present one of the 3 components of this project, and you will see through my presentation that we are a little different since we deliver our early childhood project in a 100% remote modality. And for this, we mainly use radio, but also other media to deliver all the contents in 6 departments of Guatemala that you can see in the slide. And we reach around 19,000 children, 31 caregivers that were enrolled in the project. But since it's an open media, we reach the population of the 291 communities where we were. And also this component is related to how to promote playful parenting between the caregivers and their children that are between 0 and 4 years old. Well, in the next slide, you will see that this idea started from the pandemic, but we discovered that it has a lot of advantages and opportunities to reach more families. And in that sense, we developed a series of contents based on the experience of childhood delivering early childhood programs, but also we base our content in the curricula of the Ministry of Education, with whom we have an agreement. And we wrote the radio scripts with different formats, such as informative capsules, storytelling, interviews, and original songs. And we translated, interpreted, and adapted all the content into 4 Mayan languages that are Quiché, Mam, Quechí, and Cachiquel. And we also produce with all these contents 24 radio programs. And these radio programs have a duration from 10 to 20 minutes each, and promotes playful parenting activities in those different formats. And we complemented the radio programs with 24 videos that show specific activities, such how to do a toy from recycled material, or how to play a specific game and explain deeply what is that game for. And so we created all these content. And in the next slide, you will see the different channels that we broadcast this. We use mainly the radio and mobile speakers. And this is because we cover very different communities, from communities that they don't have electricity, or they have very difficult access to electricity, to communities with mothers and fathers with technological skills. And so that's why we added the videos. And we broadcasted mainly in community and local radios, because in a previous research, we discovered that the people prefer to listen to the radio in their own Mayan languages. And here in Guatemala, these radios, local and community radios, are the ones that broadcast in the native languages. And also we use mobile speakers, that is a car that is moving in different and strategic places of the communities. And also we use WhatsApp to send the videos. In the next slide, you're going to see that every radio program has a specific goal and specific indicators. You can see over there some of the examples of the indicators in each classification. They can be aimed into knowledge, attitudes, or practices. You can see, for example, the first one says they know how to use storytelling as a means of learning. So it was included in the content, and it allowed us then to measure how people were listening to the radio programs. So if you can move to the next slide. We developed this KIP service that measured actually these indicators that were included in the radio programs. And if you can move, for this matter, we broadcasted the radio programs in 4 different cycles of each radio programs each. And at the end of each cycle, we developed a tool based on the contents and indicators, and we call by phone to a sample of the families. This KIP service also helped us to improve the next set of programs, and you will see how we did it. And here you have some of the results. For example, people prefer, the most popular channel was WhatsApp, but also the radio and the mobile speaker have a very good scope. In the next slide, you will see that some of the topics that the families identifies from listening to the radio. And in the last slide, this slide shows to us the results in terms of knowledge, attitudes, and practices. If you can see, this remote model is very useful to share new knowledge with 99% from the beginning. But the practices, we need to reinforce the content of the last 2 set of radio programs to try to have better results. And actually we did it because we reached a 94% at the end. But it means that this KAP service also helped us in our learning approach and to do adjustment at any moment that we needed to make more interesting these radio programs. And if you want to learn more about this model, you can visit juegaconmigo.org, and all the content is mostly in Spanish, but also we have some content in English, especially the one that is related to this KAP service. So thank you very much for your attention.
Great. Thank you so much, Linda. And thank you to all of the presenters for those wonderful presentations, for going into all that detail on the different iterations that you've made to your programs, the adaptations, and really what you've been learning and how you've been learning. And so with that, we do have some time for questions as well as some discussion. We have some pre-prepared questions, which I have up on the screen now. I know we've had some Q&A coming in on the Q&A box during the presentations. And I see that we've been able to address most of those questions. I think there's one question left in the open category around information systems directed to the Zambia team. So Gibson, we might call on you for that. But for this section, I will hand it over to Francis Aboud, the consultant with FHI 360 Playful Parenting Implementation Research. So Francis, I'll ask you to lead us through the discussion questions.
Okay.
And I also invite all of our panelists and all of those answering questions to just turn on your videos for this section. I'm actually going to pop these questions into the chat so people know what we'll be covering. And if you have additional clarification questions that come up, feel free to put them into the Q&A box. All right, I'll stop sharing now.
Thank you. Thanks, Tanya. So my name is Francis Aboud. I'm a research consultant with FHI for this project, and I'm going to moderate the question and answer time that's left to us. Everybody was carefully kept on track with respect to timing, so this is great. We have 20-25 minutes in which to discuss some of these questions. So I think that most of the questions that were asked of the presenters were answered well. If not, then you can holler out and say you want a better answer. But a number of them did fit into these 4 questions that Tanya has posted for us, in that some of them had to do with the workforce, which is the very first question that we were going to address. For example, how they improved the quality of delivery after getting implementation information, and also the workload of professionals, which might affect health assistants in Bhutan and community nurses in Serbia. And another question was about transferring the program to the government, particularly with respect to legislation that might need to be changed or introduced, and also cost assessments. And as Karina mentioned, FHI is doing a cost assessment, but is not yet ready to present those. So look, can we move right now into these discussion questions that Tanya posted? Are they there in the chat for everyone to see? I can, okay. So yeah. I'll just read out the first one. What changes have you made to your workforce training, delivery, supervision as you move to scale? And what implementation evidence was this based on? So I know that Bhutan already answered this question. They had quite a bit going on with respect to quality assessment and use by their health assistants, but I might call on Rwanda and Zambia to tell us a little bit about how they have handled workforce issues as they go to scale. Grace, would you like to start? Just you can keep your answers down to 1 minute, give us an idea and we can pursue it if we want to.
Yeah, thank you so much. So as I mentioned, we work with a community workforce called Inshuti z'Umuryango. In English, they are friends of families, and they work for their responsibilities in child protection. So we capacitated them on how to protect children's rights, and we are planning to continue to strengthen this capacity building we gave them. We are planning for the scale up to continue capacitating them to add gender messaging in their training materials. We are planning to add more practical child protection items in the training materials we are working on. So for the scale up, we will continue to work with the Inshuti z'Umuryango. We are planning to scale from other districts rather than the few ones we are working in. So we'll continue the Inshuti z'Umuryango capacity building for the scale up.
Okay, so yeah, you have specific people designated to do the training, cell mentors. You have a manual, as you said, that a consistent manual that everybody can use when they're training and for delivery also. Is that right, Grace?
Yeah, so we have a seed team, is a team of trained staff, for Sugira Muryango staff who are in charge of the community workforce capacity building. They are very well experienced team, and we have training materials with all the child mentoring content. That's what the content will be reviewing and rework on them, but we have already the training materials, and we have also this experienced team to.
Okay, and when you scale up, who will take over the training of the ISOs?
So for the scale up, we are planning to work with the government first. We have not yet finished our scale up strategy, but one of the scale up strategies is to work with the government to be able for the government to be able to continue the capacity of the community workforce. But for now, we are planning to continue this capacity building.
Okay,
and
great.
I'm with Jess. She can also complement it.
So maybe I'll move on to Zambia. Gibson, would you like to address that question? How have you increased the capacity of your workforce as you scale up into within these two districts to improve delivery?
Yeah. Thank you very much. I think as I mentioned, I think we are working with already existing workforce at community level, the community health workers, the SMART, but the training in terms of the playful parenting has been deliberate. And I think so that they have got the capacity and also the skills and knowledge, so that as they do their home visits on the other health issues, they also incorporate playful parenting. And also, one of the key issues that we are doing now, as I said, is to incorporate these trainings in the already existing training modules for health staff. So there's already a training module for community health workers. So basically, that's why we are trying to incorporate playful parenting into that. And basically, that will look at sustainability, so that as they are being trained on other issues, they are also capacity built on playful parenting. I also talked about the training of nurses, that all these platforms, the health facilities should be platforms for playful parenting. And also for mentoring, coaching of the community health workers. So we've been training this, and I think I've also mentioned that in the long term, we are incorporating this ECD playful parenting in the nurses training curriculum, so that it's embedded in what they already they are supposed to do in in-service training. I think one of the key issues that we've also looked at is to look at to come up to all these training modules where we looked at the gap analysis in terms of what are the nurses being trained on, what is missing, what are the ECE teachers being trained on. We incorporated the ECE teachers because one of the key principles of the methodological issue is the learning through play at ECE level. But we want to bring this to 0 to 3 so that it really transitions to the ECE. So we have done this gap analysis and we'll be able, that's why we are working on all these training packages, which
Okay,
are government packages, and that should be able to contribute to sustainability.
Okay, thank you very much. So now we're going to move on to the second question, which I think Tanya has posted. It's how have you adjusted your way of working with the government to facilitate a smooth transfer of the program? And what evidence was this based on? And I noticed that some people were indeed asking Serbia, how are you putting all of this into legislation, given that there already is some legislation that needs changing, as well as new legislation at the national and municipal level. So I'll pass this over to the Serbia team.
Thank you so much, Francis. So maybe just to have some historical look on this, so to really catch up the changes and adjustment throughout the iterations. So after the first wave of providing capacity building to local stakeholders and local authorities throughout program implementation, which was focused on the building their capacities for the implementation of the nurturing care framework. And after the establishment of intersectoral teams in all cities and municipalities where the program is implemented, we actually engage 34 local governments, so all of them which were targeted with the program, and local authorities to conduct local situation analysis in the area of early childhood development, looking into very specific and contextualized opportunities and barriers across sectors in all of 5 components of the nurturing care framework. So building on data and evidence that is actually has been collected by themselves, so not only from our side or from our end, but definitely combined with those provided through implementation research, we provide local authorities and policymakers with technical support to integrate ECD and playful parenting into the local policies, strategic documents, and to adopt a set of local measurement and budget allocation for strengthening ECD and parenting services in their communities. So with this, actually 29 new learning municipalities, because we have mentioned that we have this horizontal approach to scaling up from 6 pilot locations to 29 new learning municipalities. 29 of them in the year before, before this 4 year of implementation, they actually programmed the 80 measures of support to ECD and playful parenting. And in the ongoing parenting month, which we celebrate in all municipalities, in all of 34, local authorities are making public commitments for the long-term program and financial support to parenting and fostering community dialogue in this regard. It is rely on us to monitor. Is this going to happen really? But what is also give us a hope, is that in addition, 16 of the localities were granted financially support from the national level, from the Ministry of Family Welfare for implementing parenting support programs. And this is thanks to the national cross-sectoral coordination, but also the local self-governments are participating with the local budgets for the implementing of these grants, which is also marked as a success that we actually achieved to facilitate this different level of sources and resource allocation from the local and the national level.
Okay, thank you very much. So I'm going to sort of move on to the next question, if that's okay, because this has to do with how have you adapted your monitoring and information systems in going to scale in order to track participants? And what evidence was this based on? So somebody from Bhutan, would you like to answer this? I also noticed that somebody had asked the Zambia team if they don't already have these ECD indicators in the health system, health monitoring system. But maybe we can hear from someone in Bhutan about the information system that you're working on to track beneficiaries.
Thank you, Francis, for the Bhutan team. We go back to the pilot that was presented earlier by Emily for the Bhutan section of the presentation. So during the pilot Playful Parenting implementation that we did in 2017-18 in 2 districts, we used traditional methods of collecting data around tracking caregivers enrollment, registration, as well as attendance in Playful Parenting group sessions, and also tracking enrollment and attendance in terms of accessing the child development screening service. We used the traditional paper-based form, and we even went into lens such as having the health workers take snapshots of their registration data, the paper form, and share it to the project team and Save the Children via WeChat or WhatsApp or email. So the whole process was very tedious and a huge struggle. So learning from that experience of the pilot, when we began implementing the current scale-up Playful Parenting project in all of the 20 districts in the country through the health sector. Early on in the consultations, we engaged the IT division of the Ministry of Health, their focal person responsible for managing data in the HMIS system. And we managed to get the approval and integrate project indicators for data collection for both the Playful Parenting session enrollment and attendance, as well as the child development screening service being accessed. So that's how we've integrated it into the monitoring system of the health sector, learning from the Playful Parenting pilot project struggles. And the other point that we wanted to share from the Bhutan experience is regarding a very successful working method with FHI 360. We never had an external research partner in the Playful Parenting pilot that we did in 2018. But this particular partnership with FHI 360 is working so well. For instance, very quickly, I would like to share that initially when the project was being implemented, the Bhutan Save the Children team, we had our own quality framework for monitoring how effectively the HAs were delivering the group sessions at the health centers. And then we had FHI 360 come in, and they were also monitoring the quality of the group sessions being delivered by HAs randomly selected. And the findings shared by FHI 360 to the Bhutan team in the internal meetings between the 2 teams in country, as well as the COP that we recently had in Serbia. We then came to understand that some of the quality aspects, we were not on the same wavelength. So we then spoke to each other very honestly, understood what FHI was looking at and how we could also adapt. And now we have a uniform standard quality framework, and we know what we're looking for. And we've also then adapted and changed our monitoring quality framework for monitoring how effectively group sessions are being delivered by the health workers. So FHI 360 and Save the Children are looking for the same things. And so we can then rest assured that there will be quality. We will be successful in ensuring that a certain level of quality is maintained in the services we are providing through the project. So thank you.
Okay.
Over to you.
Yeah. Thank you very much. Yeah, the Bhutan team was very, very receptive to implementation information, and this is a great way of saying how that took place. Karma. Okay, so do we have time for one more quick question here? which is how have you expanded your advocacy strategy to raise demand, not need, but demand, which tends to be low at the community level and or at the national level, and what evidence was this based on? And I'll ask someone from the Guatemala team to help us with this answer.
Okay, thank you, Francis. Actually, advocacy is our third component, and we have learned and we have realized that advocacy is very important for the sustainability. So we added action in every level, from the community level, the municipal level, and national. And we are improving the abilities of the workforce in advocacy skills, no matter which is their role, but everybody can advocate for early childhood development. And we did these changes based on our learning approach, where we discuss about how doing advocacy in only one level, that is what we used to do, wasn't very useful. And we also have feedback from local authorities and realize that they have a special commitment with the childhood of their communities. And this is what motivates us to do these certain changes.
Okay, great. Would anybody else like to come in and talk about advocacy within communities and at the national level?
I can very quickly reflect that we have some experience related to how to say, enabling space for the frontline workers to be more vocal, related to their position, to their willing to expand the way and to increase the quality of the way of how they deliver service to the families, and all the requirements they need to that they need to be in place for them, so that they can provide quality at scale for the caregivers. However, the room for the improvement stays with having parents as frontiers in this demand-based advocacy efforts, and it is already drafted in our plan for the last year of the implementation.
Okay, thank you. Yes, I think most of you are using some form of mass media, as well as speaking directly to government people who need to enact this legislation and put in a budget line, two of which are the most difficult aspects to sustaining and scaling this. Okay, so I think I'll pass it back to Tanya and let somebody do the closing remarks. Thank you very much for your very insightful questions and answers to these questions.
Thank you, Francis, and thank you to all of the presenters for those responses. I think we have a couple more minutes. We have two more minutes or so. I see that there's a question that just came in on the Q&A box, so maybe we can address that. On volunteers doing the job in case the program will end.
Okay. So I did try to answer that a little bit in that nobody here is using model mothers, I should say, as delivery agents. I know that some people do this in lots of places, but the attrition is obviously very high. So even with these volunteers, attrition is high, and there needs to be sort of constant training. There's complaints from them, but other people have used the community health workers and the volunteers to supervise mothers in many sections. Even in Serbia, I remember some mothers in the focus group saying that they like to meet with other mothers, and they don't really want an expert there telling them what to do. They want somebody who can answer their questions. So this is a good question that other people need to follow up, in that mothers in villages are very receptive to other mother models, and they clearly should be used in one way or another, but to make them the mainstay of the program creates a little bit of a problem in sustainability and scaling. Somebody else asked a question about urban versus rural. I think in all of the places where our partners are working, the level of stimulation and responsive caring is low, and this is why there is a need for these programs. There's no question about that, although the need seems to be greater in rural areas. But as to which parents are more receptive to these programs, I should say in many cases, parents are not receptive. They say, I don't need this stuff. What is this? Until they get a few ways into the program, and then they say, oh, now I see what the point of this is. My children are so much happier and so much more active. So in the end, I'm not sure who is more receptive, but clearly they're starting at a different baseline level. If anybody would like to comment on that, please do. Mila is probably doing both urban and rural, although most of the others are mostly rural.
Well, it just reminded me then when I spoke with Xenia and our last, in-depth interview, and when we tried to list it and to discuss the gaps and the bottlenecks, we also recognize that in these 20 new municipalities, starting point was quite different in the different municipalities, which also requires from us to be quite flexible and to really have a tailor-made approach to all of these municipalities. So definitely having this focus on the really specific context of the child, mother, family, and service providers, it helps to be more relevant.
Thank you. That's a great answer on which to finish. Thanks a lot, Mila. Pass it over to you, Tanya.
Wonderful. Thank you so much, Francis. And thank you again to all the presenters for those reflections. I will now hand it over to Amanda from GIST/ECDAN to close us out. Thank you.
Thanks, Tanya. And first of all, I wanted to say thank you to all of our panelists and presenters today, as well as to all of our attendees. We've had some really great presentations and also some really great engagement and really interesting discussion, both just now and in the Q&A and in the chat over the course of the webinar. So I wanted to thank everyone for that. As Tanya said, my name is Amanda Germanio, and I'm the Global Coordinator for the Global Initiative to Support Parents. And we've learned so much about the different pathways to scaling playful parenting and caregiver support interventions through the 5 countries today. I'm going to be doing the closing today in the few minutes we have left, but there's just too much information for me to summarize in just the remaining minutes. So I will let everyone know that we will be circulating the recording and slides from today's webinar after the webinar is done. And you can also look in the Q&A for additional answered questions if you haven't already looked there. So first of all, I've noted a few key takeaways over the course of the discussion. One is the huge diversity of parenting interventions that we've talked about today. This is in terms of providers, how these providers engage our caregivers, intensity of the programs, and the different impacts and outcomes of the caregiver and on caregivers and children. This can range from child health impacts to caregiver mental health to violence prevention to other outcomes, as we've seen today. There's also so many different pathways for translating innovations into standardized practices and for scaling them and ensuring sustainability, including different ways of engaging with governments and with different ministries, and for transferring responsibility to governments for legislation and cost assessments and for other aspects of ensuring scale and sustainability for these interventions. We've also seen the huge need for flexibility and the role of innovation in parenting caregiver support interventions when circumstances change, and the need for general flexibility in terms of workforce training and development and supervision, and when external factors mean we need additional changes as well. We've also heard on the need to continue to engage men and male caregivers, as well as the need for multi-sectoral coordination for parent and caregiver support interventions. So even though all these programs are ECD, the need to engage with other sectors has been evident. And also, as we've seen from the discussion and some of the discussion questions at the end here, we've also heard about the benefits of sharing learnings between countries and different interventions and programs, and creating these opportunities for different partners working in the parenting support sphere to learn from each other. And we hope that this webinar has been a continuation of that today. So where do we go from here now that we have all of these great programs? We know that parent and caregiver support interventions are effective in different settings, which we've seen in part from today's presentations and from the continued emerging evidence of effectiveness. But we also know that only 26% of governments report that they're reaching all parents who need it, according to the Global Status Report on Preventing Violence Against Children. And we also know that in spite of the wide range of outcomes that parenting interventions cover, interventions are often siloed across sectors or limited to one age group only rather than being scaled continuously across the life course, which is how we can be most effective in achieving universal support. So in order to achieve quality, evidence-based, and universal parent and caregiver support, a group of partners came together to initiate a global initiative to support parents as a global platform for parenting support across sectors and across the life course. GIST brings together partners from around the world with the goal of transforming government recognition and resourcing for evidence-based parent and caregiver support, and with the goal of creating synergy between separate streams of parenting support work that haven't previously been in touch with each other. So we do this across 4 pillars. This includes advocacy, evidence generation, and knowledge sharing, innovation, and scaling. And I think we've seen all of these pillars reflected in the presentations today. And in particular, this webinar is part of our evidence pillar to encourage learning and to share some of the evidence that's being generated currently between the different stakeholders. We've seen the great presentations from our partners today, Save the Children, FXB Rwanda, UNICEF, FHI 360, Child Fund, and other partners who've supported implementation and learning. And we also want to encourage other ways of getting involved in the future so that you can continue to be engaged with parenting around the world. So we had a webinar today. If you would like to collaborate on future webinars or have ideas for future topics you'd like to see, feel free to always reach out. We also have a global parenting newsletter where we're always happy to share evidence that is emerging or country updates. The Global Initiative to Support Parents has a brand new website and knowledge hub, and we're accepting inputs on evidence and future events. So feel free to share so that you can reach the broader parenting community. We also had a great global parenting town hall yesterday where we heard from priorities of different countries and different program implementers, and would like to have more of those in the future so we can hear from the broader community. We also have a Middle East regional convening for anyone located in or working in the Middle East. That will be from August 8th to 10th. More information on that is forthcoming, and look out for the save the dates. And we're also excited to announce a global parenting forum coming in June 2024. So this webinar has really been a really exciting wrap up of a great parenting month. June 1st is Global Day of Parents, and we've continued this throughout June. And we really want to keep moving this forward and continue the momentum as we move towards a global parenting forum. It's been really great seeing all of the evidence and work that's been going on throughout the whole month and during this webinar. And I wanted to thank all of our presenters and attendees again as we keep moving this conversation continuously forward, highlighting new evidence and showing all the great work that's being done around the world. So I just wanted to thank all of our attendees and all of our participants. I know that we have gone a little bit over time, and I wanted to apologize for that, but thanks to everyone who has stuck around to the end, and thanks again to everyone.
Thank you so much, Amanda, to all of the presenters and to all our attendees. We look forward to continuing the conversation. Thank you. Thanks for joining.